case reports, because it's always quite nice to have some case reviews so that we can talk about real life patients that I've seen. And it's of note that certainly in the Northern European rheumatology departments across Europe, polymyalgia and GCA, giant cell arthritis, are extremely commonly encountered diseases. There's a very active patient support group in the UK for polymyalgia rheumatica, PMR and GCA, and they seem to have me as one of their popular consultants, I think, because I usually talk common sense and help people to make their way through the mire of advice that is given to them for steroids and how to deal with them and their side effects. So I get a lot of patients referred into me from outside my own area who have encountered problems with polymyalgia, and usually they're the 10% of people with difficulties. I'm going to talk about the 100% of people, including the ones who have a straightforward illness. We're just seeing a few more people log in at the moment, so I'm just going to leave it another couple of minutes. We're getting a few more people joining in. I think our numbers are going to be reasonably slim because of the time of year and the fact people are busy, but hopefully you can jot down some questions. I'll be able to stop perhaps after London. We'll be muting you all so that the contributions will be online, and so you get a nice clear recording of the talks. So here we go. So this is one of a series of RELA webinars. It's probably the third one I've done in sequence, and I've got another 2 or 3 to do in the New Year's season, and I tend to cover a variety of rheumatology subjects. The last one we did was looking at urgent rheumatology presentations. So the difficulty with polymyalgia rather than giant cell arteritis is a lot of patients have heard about it, and a lot of patients have decided for themselves that they have got polymyalgia, and they sometimes come and tell the doctors what they've got wrong with them. This lady's saying, I've already diagnosed myself on the web, but I thought I'd come in for a second opinion, and the doctor looking suitably nonplussed. Now, it sometimes works the other way round, and the doctors, the primary care family doctors, haven't thought that polymyalgia may be a cause for a gradual onset stiffness in the shoulders and the hips, and think that, well, do you know, what can you expect? It's what happens with old age. It's a lot easier for them to diagnose polymyalgia when it's a rapidly developing, perhaps overnight illness, and when it's associated with elevated levels of the markers of inflammation, the CRP and ESR. But unfortunately for diagnosis, a significant minority of people have a much more gradual onset, and a significant minority of people have no abnormal blood tests. So our first point is that not all that seems like polymyalgia rheumatica is polymyalgia rheumatica. So here's a case. This is a case of ASPH, is Ashford St Peter's Hospital, where I work. And this was the mother-in-law of one of the pathology technicians at the hospital, who phoned me up and said, oh, could I possibly see his mother-in-law, because she's struggling to manage. She's starting to get very immobile. And I said, yes, I would. And she came to see me just before COVID lockdown in October 2019. We locked down in the UK in March 2020. And I saw her as a second opinion. When I saw her, she was 80 years old, and she'd been seen within our own hospital by the care of the elderly or geriatric team as an outpatient. And the diagnosis had been made a few months earlier, in May of 2019, of polymyalgia. It was a little unclear on what basis they'd made the diagnosis, but looking back through the records, she definitely had had a degree of elevation of her inflammatory markers, and they started her on a very enthusiastic polymyalgia treatment regime of 30 milligrams of steroids, and after 4 months she was down to 22 milligrams a day. So she had a past history of asthma, of what sounded like hypertensive cardiomyopathy to a mild degree, and of mastoiditis, and eventually had a mastoidectomy for this very painful condition. And the story she gave directly was that she started to feel unwell in early 2018. So somewhere over a year before she was started on steroids. And she'd had progressively difficult walking and was starting to go out of the house less and less. And her blood tests, of which numerous blood tests had been done, showed a slight elevation of ESR at various levels. And as you all know, the older you get, the more likely it is you have a slightly elevated ESR. And her highest ESR was 44, which is not terribly impressive in an 80-year-old. And on direct questioning, she had never presented with a proximal myalgia. So myalgia being muscle aches and pains, and proximal meaning above the elbows and above the knees. She'd had no symptoms at all in the arms, but she felt generally that her muscles all over were sore. And in particular, she'd felt fatigued and lethargic, and her main issue was progressive difficulty walking. So even starting at 30 milligrams of steroids a day, at no stage did steroids make any difference to her symptoms at any of the doses, and this would be vanishingly unusual. Normally the seal on the diagnosis of polymyalgia, even if there's some uncertainty beforehand, is made on the basis of response to steroids. And at 30 milligrams of steroids a day, you are going to get better with polymyalgia to at least 50% a degree of symptom relief over about 2 weeks. And none of this happened, but her ESR fell from 44 to 32. And this seemed to have satisfied the clinician who was dealing with her. And as a result of the steroids, she'd developed swollen ankles since August, when the steroids had been increased because the ESR had gone up a little bit. It's likely that the steroids were producing an effect of fluid retention, and it's likely because she had atrial fibrillation and a benign hypertensive cardiomyopathy. I mean benign by the fact that it wasn't progressive and wasn't serious, but she was clearly retaining fluid, and she'd then been given 60 milligrams of furosemide. The steroids hadn't been adjusted, they were still at 22, and this had made a slight difference to her ankle swelling. But here she was, feeling somewhat bewildered that she was treated for a condition which she didn't seem to have, with a drug that didn't seem to be making any difference except causing side effects. So to me, when I saw her, she complained of numbness and tingling in the lower legs below the knees, not in the upper legs where you'd expect polymyalgia to be. And she complained of weakness of the legs, worse below the knees. So this was contradictory to the area you would see polymyalgic symptoms. But you can see how the diagnosis got perpetuated by the doctor's insistence on following the ESR level. And clinical examination showed she had a sensory level to the mid-thigh. So sensation to light touch to painful stimuli. In the clinic, we don't tend to do hot and cold, but one would presume that was also impaired. And she had a perceived weakness, but when her muscles were tested, she had relatively full power that was preserved. She had absent knee and ankle reflexes, and this is sometimes seen as an age-related issue, but she had downgoing planters that were sluggish, and her investigations just before she was seen by me showed a normal full blood count, normal thyroid function, which is important because that's another mimicker of polymyalgic symptoms, a normal CK, creatinine phosphokinase, which goes up when muscles are inflamed, so another important differential. She was a little bit low on her iron, ferritin, but had a normal hemoglobin, and her ESR was 31. I had significant doubts about her having polymyalgia. A, because she didn't fulfill any of the diagnostic criteria for polymyalgia, which we will go over. B, because she had no response to steroids. and C, because she had no evidence of any endocrine or metabolic abnormality that might be mirroring polymyalgia. So she didn't even fulfill the criteria for the differential diagnosis of polymyalgia. So from my perspective, and I'm not one to criticize other doctors easily, this was way off target. So I thought, well, did she have something in the lumbar spine causing problems, a bone or infiltrative lesion of the cord? Did she indeed have a steroid myopathy? Was it that the steroids had produced the weakness, even though it wasn't quite right for that? Or did she have subacute combined degeneration of the cord? And this is a condition where the nerves that are used for motor and sensory uh, control of the lower limbs are affected by a vitamin deficiency. In this case, vitamin B12 is the most common cause of subacute combined degeneration. So what did I do? Well, I looked through the notes, and there, staring in front of me, was an inadequate vitamin B12 that had already been done in July 2019, well before I saw her in the October, and well after the May steroids had started. The normal range in our laboratory being 246 to 911, and because there's an enormously wide range on B12, you can still be B12 deficient even if you're in the lower reaches of the normal range, but in this case she was well below the normal range. What did I do? Well, I also did a CT scan because I'd order it of the lower lumbar spine, and that didn't show any abnormality at all. I just wanted to be sure that it was going to be the B12, and treated her with intramuscular B12, which has a fairly fixed protocol of 1 milligram of B12 given intramuscularly every other day for 7 injections. So over a 14-day period, 7 injections, which seem to load the patient up with B12, and then a repeat every 3 months. And within 3 months of the B12, she had completely normal recovery, including the dull and absent reflexes returned, the sensation returned, the power returned, and all the symptoms diminished. And by Christmas Day, or just before Christmas Day, when the family were putting up the Christmas tree, she was able to climb up a step ladder and put the fairy on top of the tree. I wasn't quite sure that that was what an 80-year-old should be doing, but was quite pleased to see her coming back into clinic just after Christmas, out of her wheelchair and walking perfectly normally. So beware making the diagnosis of polymyalgia rheumatica in every elderly patient with muscle issues or apparent muscle issues, because there are other differential diagnoses. Very rewarding to treat indeed. So what about another case, an alternative polymyalgia presentation? So here's a slightly younger lady, Mrs. S.E., who's normally fit and well. She plays golf around our part of the world. Lots of people play golf. It's got a lot of very good golf courses. Sadly, in my working life, I've never quite managed to catch up with golf because I don't ever seem to find 3 or 4 hours that are free. But now my children are growing up, and gradually that one's gone to university and the second is shortly to follow, I may well have time to start playing golf. But this lady was had plenty of golfing time, and she walked her dog and she met her friends, and she was quite normal, fit and well at the age of 68. She then developed shoulder pain almost spontaneously, which she thought was maybe she'd mishit the golf club somehow. And she got pain in the left shoulder. And then fairly quickly afterwards, pain in the right shoulder over a 2-week period. And she was worried about this because it was stopping her from using her shoulders. And they were gradually losing their ability to elevate the shoulders fully. But they weren't by any means frozen. A frozen shoulder is when the shoulders are stuck to your side and you can't move them out. But she went to see her GP, who diagnosed her as having frozen shoulders and said, oh, well, what do you expect playing golf? And gave her anti-inflammatories and PPI drugs to stop the anti-inflammatories upsetting the tummy. and she got 10 or 15% better. So she was starting to believe the story that this was just because she'd mishit a golf shot. However, despite the anti-inflammatories, she started to develop aching in the neck. She was fatigued, unusually fatigued, and not just because she was waking at night due to profound stiffness that was developing, but she was also getting symptoms in her thighs that instead of these being a frozen shoulder, they were attributed to a bursitis by the GP. And the GP is, of course, quite right, because bursitis is a cause for discomfort in the upper outer thighs, but it doesn't tend to cause muscle aching. It tends to cause pain over the outer side of the thigh where the trochanteric bursa, or across the back of the bottom where the gluteal bursa is. So she carried on with her anti-inflammatory, which has changed from naproxen to diclofenac, and the concept that this might be stronger. She was taking them regularly, but even in spite of that, she started to feel very stiff indeed. And her GP did some more blood tests and saw that the ESR was normal at 15, so went through the process of thinking, well, she might have something inflammatory, but no, she can't have if her ESR is normal. And her stiffness was then attributed to osteoarthritis. And you'll remember that this is all happening over the period of 2 or 3 months. And certainly I know of no patient who's developed progressive osteoarthritis to the point where they can't mobilize and they wake up stiff at night over a 3-month period. So it's inconceivable that the diagnostic labels on this lady were explaining her symptoms. By 4 months, she was unable to use her bath, which she enjoyed using, had to use the shower, couldn't easily get a restful night's sleep, and was sent to the physiotherapist by the GP. And the physio said, yes, I agree, it's frozen shoulders and bursitis. And she had 7 very painful sessions of physiotherapy with no benefit, and was now reliant on multiple doses of anti-inflammatories every day. And eventually, I think out of a sense of despair because she was haunting the GP referred her to see me in rheumatology. She wasn't able to rise from the chair in the consulting room without using her arms, quite a good clinical sign. She was unable to actively move her arms above her shoulders, although I could take the arm and move it passively into full movement, which is very typical of a myalgia and not very typical of a frozen shoulder or adhesive capsulitis, because you cannot move the shoulders in passive movement. She was very tender and uncomfortable in the muscles on resisted movement of the thighs and shoulders, even on movement against gravity. And she was extremely stiff, especially in the mornings for the first 2 or 3 hours in the proximal muscles, so the shoulders and thighs above the elbows and above the knees, very typical of a polymyalgia picture. Her ESR was stubbornly normal. I did it again from clinic. CRP was normal. And I said, okay, look, I think this is a likely polymyalgic diagnosis. And I was very careful to ask about the index symptoms of giant cell arteritis, because these two conditions travel together. And about 25% of patients with polymyalgia are thought to have a degree of vasculitis, whether in the temporal arteries or the other cranial arteries. She had had no headaches, a typical symptom, no visual symptoms of loss of areas of visual field, no tenderness over the scalp, and in particular, no jaw aching. And there's a symptom called jaw claudication, which is a sign of giant cell arteritis, because the muscles of mastication are muscles that are supplied by blood vessels that get inflamed. So when you start to chew enthusiastically, you develop the same sort of claudication that patients with impaired peripheral arterial supply to legs get when they walk, except this is in the jaw. So I gave her what would be our standard dose regime for polymyalgia, 15 milligrams of steroids for 2 weeks, within 12 hours, even to the point of seeing the packet with the steroids in and opening it and sniffing the steroids. She started to get better. And that's often what you see with polymyalgia. It's a very rewarding treatment to give, especially in the UK before Christmas, because you will always get a Christmas present and supreme gratefulness as a result. And all you've done is recognize a pretty obvious diagnosis. Her fatigue responded because the steroids were mopping up the interleukins, the cytokines that the inflamed cells were pouring out that mimic the symptoms of influenza. And best of all, her stiffness in the early mornings resolved. And it was fair then, because she was fulfilling lots of criteria for polymyalgia, to diagnose her as polymyalgia. So what's a normal presentation? Well, do you know, a normal presentation of polymyalgia is pretty similar to that. It's pain and stiffness in the shoulder, neck, pelvis, back, never below the knees, never below the elbows. It's often, by the time it's developed, fully bilateral and symmetrical, but when it starts, it's often unilateral, asymmetrical, and can be just the shoulders or just the legs. It's often accompanied by a synovitis, a swelling of the peripheral joints to a low grade. So it looks like a very low grade rheumatoid arthritis type inflammation. And that can be in the knees, wrists, and in particular in the sternoclavicular joints of the shoulders. And muscle strength is typically unimpaired, but movement inhibited. So the muscles appear to be weak, but they're not. They're stiff and uncomfy. And the patient can have the symptoms of IL-1, IL-6, and TNF secretion as fever, weight loss, and malaise. So these are the diagnostic criteria. There are several sets of diagnostic criteria, but these are reasonably good ones. So the first three must be positive, and any number of others. So pain and stiffness in the proximal girdles, not specifying upper or lower limb. The steroid responsiveness must be greater than 70% symptom improvement with 15 milligrams of oral prednisolone over 2 weeks. Now, just because people can sometimes have 50 or 60% doesn't mean it would take you away. But if they had 10 or 20%, you would be saying, look, this isn't polymyalgia, or if it is, it's an unusual polymyalgia that requires a slightly higher steroid dose. And the patient must be older than 50. And I've only ever seen one person with polymyalgia under the age of 50, and they seem to have had a rather unusual drug-induced polymyalgia from a statin that really was polymyalgia because it responded very well to steroids. But the SR greater than 40, I don't buy that first case of 44 or whatever it was. They must have normal thyroid function tests, and they must have a normal myeloma screen, because myeloma is the other important thing that is a differential diagnosis of proximal myalgia. And they might have had weight loss, fever, or joint pains. So the bottom three are helpful. The top three are important. So what polymyalgia can sometimes do is to develop into a more classical rheumatoid arthritis. And it's estimated that perhaps 25% of people who start polymyalgia end up with rheumatoid arthritis. And in retrospect, you realize that their polymyalgia was a polymyalgic onset of rheumatoid arthritis. And the thing to be careful about is that both polymyalgia and temporal arthritis can sometimes develop alongside a trigger cancer that is either there before the polymyalgia or temporal arthritis occurs, or when it's already diagnosed and in retrospect we're already there. So watch out for any red flag signs like weight loss, which can be explicable by polymyalgia, but you would be inclined to do a CT screen of chest, abdomen, and pelvis if someone had had significant weight loss, just to check they hadn't got a polymyalgia that was associated with a tumor. And that's the way to investigate red flags. And any other red flags, such as unexpected blood tests like increased calcium. Who gets polymyalgia? Who gets temporal arthritis? And you'll see that in this presentation, as in the world about us, temporal arteritis and giant cell arteritis are used interchangeably. Temporal arteritis to imply it's the temple arteries that are affected, and giant cell arteritis to imply that the histological outcome of a temporal artery biopsy can often be to show giant cells, and I'll show you a picture of that. So the epidemiology is predominantly in the white population, although not exclusively, predominantly and exclusively in the over 50s. And you can see the difference in incidence across temporal arteritis, which is around 200 per 100,000 per year, and polymyalgia, which is 3,300 per 100,000 a year. There seems to be a loosely based HLA link, a loosely based female link, possibly because, like most other connective tissue diseases, sex hormones can play a role in the triggering of these conditions, and an average age of 70 for the polymyalgics. The average age for temporal arteritis is a tiny bit younger. So what is this GCA temporal arteritis? Now we know a little bit about polymyalgia. Well, it's a systemic vasculitis, often accompanying PMR. It's known as granulomatous arteritis, temporal arteritis, or giant cell arteritis. And because it's a vascular inflammation of the medium-size blood vessels in the cranium and upper torso, it can affect some pretty significant blood vessels. So it can affect the axillary arteries and the carotid arteries. It can affect the intracranial arteries, in particular the retinal artery, and like any other arteritis, not arthritis, but arteritis, it can cause clotting of the blood vessels, and in the case of the eyes, irreversible blindness. And it usually needs higher doses of steroids than polymyalgia because you're a little bit more frightened about not completely controlling the inflammation, because the consequences of arterial blockage are more significant than the consequences of being stiff in the mornings. And pretty much always temporal arteritis presents with headaches. They can be severe and localized. They can be across the whole scalp, and a tenderness of the scalp and global headache can often be misdiagnosed as some form of migraine or cluster headache, when actually in retrospect it's temporal arteritis. They can often have a low-grade fever. We've talked about jaw claudication. We've talked about transient visual field losses, including a slight mistiness. And if you were to watch the natural history of temporal arteritis in the olden days before steroids, somewhere between 5 and 10% of people with these conditions would develop an irreversible blindness. And because it's a vasculitis, it can cause stroke and deafness and hearing issues, and often these can go unnoticed as a inflammatory complaint. And how do you then find it's an inflammatory complaint? Well, because 99.999% of patients who present with temporal arteritis have a significantly elevated ESR and CRP, which is not the case in PMR. You can get a peripheral neuropathy. You can even get depression as a sort of consequence of multiple areas of vasculitis. And you can start to get pretty catastrophic things like aortic dissection and problems with the heart, liver, and thyroid, all the vascular sort of organs. And this is a superficial temporal artery. And when I started rheumatology many years ago and was a young trainee doctor, we used to do our temporal artery biopsies in the treatment room off the side of the ward until it became pretty clear that these were relatively aseptic but not sterile conditions, and that any issues that arised were much easier to deal with if they happened in theatre. And now all temporal artery biopsies are done on the end of vascular or orthopedic lists. And here is an inflamed temporal artery. And often if they're this inflamed, they're relatively non-pulsatile because they are swollen and have big, thick blood vessels, and it sort of masks the pulsatile nature. If you feel your own temporal arteries, you might not even be able to feel them, but if you feel them, you can feel that they're pulsatile. Don't panic if they're not, you're just feeling in the wrong place. Minor operation, small piece of artery, sometimes unfortunately a little bit of gristles taken instead of a bit of artery, and should always be considered in temporal arteritis, but is often extremely difficult to obtain because inevitably you're trying to do it on a Friday night. And if you use the steroids straight away, which you need to, within a few days, otherwise abnormal biopsy can turn normal. And this is 3 days after a biopsy and a few weeks later, and you can see there's pretty much nothing left of this. Curiously enough, the patients changed color, but actually they're two different patients. And here is a temporal artery biopsy with a huge amount of inflammation in the muscular layers. And you can see these great big, this particular one, if you can see the cursor, great big multi-nuclear giant cell. And here is the giant cell in higher focus, and that's why it's called giant cell arteritis. There are alternative ways of imaging, and now pretty much everybody has in their hospital, if they have Doppler ultrasound, a radiologist or radiographer who's skilled in doing an ultrasound of the temporal arteries, which have about as much discriminative power as a temporal biopsy. So it's a very good alternative, but it's very observer based in that it's up to the observer to know how to do this particular ultrasound. PET scanning isn't used very much because it has a resolution of 3 mm or above, and most of the arteries in the head, and especially the superficial temporal arteries, are not that big, and therefore they don't show up on PET scanning. But PET scanning is quite useful for looking for the evidence of systemic arteritis in the large blood vessels of the rest of the body. And a PET scan is pretty useful because it can reveal the extent of vasculitic involvement, but it can also assess how well treatment for vasculitis is getting on, but it's not available everywhere. Imaging, temporal arteritis and large vessels. Ultrasound, Doppler is the one to use, duplex. This is a duplex Doppler, and it shows what's described as a halo effect, where you actually seem to be able to see the narrowing of the vessel and the blood going through a narrow segment of vessel. And temporal arteritis can affect all of the large and medium blood vessels through the body, and you can see around the head and neck there are lots of red labeled arteries that can be affected by temporal arteritis. So there have been some studies doing temporal artery biopsies in patients with polymyalgia and no temporal artery symptoms, and between 10 and 15% of those biopsies have been normal. It's not a routine thing to do. Have been abnormal. It's not a routine thing to do in polymyalgia, but these are in little small studies. Headaches almost always occur with temporal artery inflammation, but are rare with polymyalgia. So if they do occur in polymyalgia, then you're probably revealing a degree of temporal arteritis. So always inquire when you see a patient with polymyalgia whether they've got headaches, jaw claudication, or anything that might be tenderness of the temporal arteries. So what are the long-term consequences of PMR and TA? Well, one of them is that you have to use the steroids for quite a prolonged period of time, and therefore you can get steroid side effects. And one of them is that if you do have residual inflammation over a sustained period that's affecting the large blood vessels of the torso, that can weaken the blood vessel walls and cause aortic aneurysms. And there are some authorities that suggest that patients who are diagnosed with and recovered from temporal arteritis should have an annual chest x-ray to ensure that they're not developing significant aortic aneurysms. We don't actually do that because the incidence of these complications is low. And here is an aortic aneurysm from temporal arthritis. And here's a study from Minnesota on 2,000 patients where it was shown that temporal arteritis patients were 17 times more likely to develop thoracic aortic aneurysms than non-temporal arteritis patients. And they were 2.5 times more likely to develop abdominal aortic aneurysms. And this was the study that suggested annual chest x-rays. So what about the pitfalls? So an ESR is normal in 10 to 20% of cases of polymyalgia. Some people, and I've sat in presentations from authorities close to where we live and work to say that's absolute rubbish. It's always elevated and you can't diagnose polymyalgia if it's not. I absolutely can guarantee you with 30 years experience of rheumatology, I've seen a number of patients with very typical polymyalgia with normal ESRs. So beware the normal ESR. And it's because people are variable in their ability to develop high ESRs and CRPs. And I've seen patients with the most florid rheumatoid arthritis who have florid inflammation but no elevation of ESR. And it's not a good way to monitor response. It's very non-specific and is an indicator of diagnosis in some cases, but not in others. We've already talked about vitamin B12, myeloma, myositis, and hypothyroid, but vitamin D deficiency can cause proximal myalgia. It is the first sign of osteomalacia, which is a bone issue that is secondary to vitamin D deficiency. So as we, surprisingly enough, draw to a close because it's 39 minutes past 3, non-steroidal anti-inflammatories can help the management of polymyalgia, but they often result in a delay in diagnosis because they help by 10 to 15% and stop people complaining. And therefore, they can be both useful to the patient because they're better than nothing, but a delay in the diagnosis. And for polymyalgia, it is typical to start 15 milligrams of prednisolone for 2 weeks before seeing the patient and seeing if they have polymyalgia, and 40 milligrams of prednisolone for patients with temporal arthritis. A number of guidelines suggest 60 or 80 milligrams, depending on whether there's visual involvement, and usually the dose is ramped up if there's visual involvement. Always consider bone prophylaxis to prevent osteoporosis, because everybody going on to steroids of 7.5 milligrams or more anticipated to be using them for 3 months or more, which is exactly the case for polymyalgia and temporal arthritis, will lose significant amounts of bone. So we routinely talk to people about going on to alendronic acid at the start of their treatment, or alternatives such as zoledronate, which is an intravenous annual bone protector, or denosumab if they have any swallowing difficulties and can't take an oral bisphosphonate. Don't reduce the steroids too fast, and don't reduce the steroids according to the ESR, because both temporal arteritis and polymyalgia, but polymyalgia in particular, is a clinical disease with a clinical course, so should be monitored according to symptoms. And beware when flares occur, because sometimes you can get into this cycle of upping and downing the steroids, and you lose not only the will to live, but also the ability to know what you're treating. And if there are very profound steroid adverse effects, there is a little bit of literature in polymyalgia rheumatica that leflunomide, methotrexate, or azathioprine can be used as a steroid sparing agent, and in temporal arteritis that tocilizumab, IL-6 infusions or in injections, subcutaneous, can be used to help as steroid sparers in the treatment of temporal arteritis. This is standard for polymyalgia: 15 for a month, 12.5 for a month, 10 for a month, 9 for a month, 8 for a month, 7 for a month, etc. Some people have to go a little bit slower. Some people can go a little bit faster and do it every 2 weeks, and you have to gauge it according to the response. We tend in our practice to encourage general practice to be in charge of the titrating symptoms, because if it goes according to the guidelines, we don't need to see them. And if it doesn't, they can refer people back to us. Duration of both conditions, 18 to 36 months. Only 5% need steroids for longer than 36 months. Both conditions are unlikely to recur, but possible. Estimated no more than 5% have a recurrent episode of temporal arthritis or polymyalgia. And occasionally, temporal arthritis blossoms in a very unpleasant way, not like a scented rose, but like a real prickly nuisance when polymyalgia is being treated, despite the fact that the patient's already taking some steroids. Don't miss the diagnosis. These are common diseases. Educate the patient to aid adherence to sticking to steroid regimes, and use some form of literature. Nowadays, I point people towards the internet rather than actually giving them handheld leaflets. Always use bone prophylaxis unless either they're already on bone prophylaxis or they can't tolerate it. Always attempt either imaging or biopsy proof for temporal arteritis, and remember that polymyalgia can sometimes develop as rheumatoid arthritis later, and that becomes manifest as the emergence of inflammatory small joint arthritis in the PIPs and MCP joints, even when the patient presented as polymyalgia with little or no symptoms. And as the steroids are reduced, so the amount of inflammation is increased, and then you end up relabeling the patient and using more rheumatoid-based medicines such as methotrexate. So there we go. If we then just go back to the title slide, I promised you 40 minutes or so, and you've got 40 minutes or so. It's now 3:44. I would be delighted to take any comments, which I deal with one by one, or any questions if you care to put anything on the chat box. At the moment, I can't see anything, but please feel free to do so. But also, don't feel obliged to, because if now you know everything you want to know about polymyalgia and temporal arteritis, then I'm very happy, and very happy for you to just say, look, as Dr. Sarja does, very interesting, useful lecture. Thank you, Dr. Sarja. The diagnosis, think about it, and don't miss the temporal arteritis hidden under the polymyalgia. Do always ask about headaches, temporal artery tenderness, but also scalp tenderness. And I think it's quite an elusive presentation when you present with scalp tenderness all over, because you tend to think about something like shingles or some other scalp irritation or eczema, but actually you can get a low-grade rash with temporal arteritis across the scalp. And I think be very, very aware that you need to be managing these conditions according to clinical symptoms. Otherwise, you find people have been left on prednisolone at high doses for a long period of time because their elevated ESR is present because of some other stimulus. So I wish you all a very good afternoon. For those of you who celebrate Christmas, I wish you all